Hello guys. Welcome to the Docsaab's Diary. And today we are diving into a common yet often overlooked parasitic skin infestation, scabies. This is the itch that never sleeps, and understanding it is crucial for family medicine practitioners like us. I am your host, and we will cover causes, symptoms, diagnosis, and treatment based on current evidence. Let's get started. Scabies is caused by the microscopic mite Sarcoptes scabi war hominis. These tiny invaders burrow into the upper layer of the skin where female mites lay eggs, triggering an intense allergic reaction. It is highly contagious and affects all ages, especially in crowded settings like households, schools, or nursing homes. Globally, over 300 million people are affected annually, with higher rates in tropical and subtropical regions. In India, it is neglected tropical disease with the rural prevalence up to 59% and urban rates around 13 to 21%. Transmission happens mainly through prolonged skin to skin contact, think sexual activity, hugging, or sharing beds. Indirect spread via contaminated clothing, bedding, or towel is less common but possible. Might survive up the body for just 2 to 3 days in warm, moist environments. Risk factors including overcrowding, poor hygiene, immunosuppression like HIV, and institutional living. In New Delhi, urban studies showed 2.9% prevalence, while rural areas hit 13 to 21 percentage. And no, it is not typically zoonotic. No easy jump from animals to humans. The human itch mite's life cycle on the skin lasts about 10 to 17 days. Fertilized adult females, just 0.3 to 0.45 millimeters long, burrow into the stratum corneum, then creating a serpentine tunnels 8.5 to 5 millimeters per day. They lay 2 to 3 eggs daily for 4 to 8 weeks. Eggs hatch in 3 to 4 days into the larvae with 3 pair of legs, which move to the skin surface to molt. Larvae mature into protonymphs with 4 pairs, then tritonymphs, and finally adults in 3 to 4 days each. Males mate on the surface and die quickly, only impregnated females burrow. Off-host survival limited to 2 to 3 days at room temperature, and this cycle explains why symptoms build up over weeks. The hallmark is severe itching, often worse at night or after bathing thanks to mite activity. A pimple like rash appears as red bumps or small blisters, typically on wrist, elbows, waist, between fingers, armpits, and genitals. Burrows, tiny thread like tracks 1 to 10 millimeters long, may show up especially on thin skin like finger waves. In crusted scabies, a severe form, thick crust form on the palms and soles, harboring thousands of mites. It causes minimal itch but extreme contagiousness, seen in immunocompromised patients like those with HIV or elderly. Secondary issues including scratching leads to sores, risking bacterial infections like impetigo, cellulitis, or rare systemic problems such as sepsis, heart disease, or kidney issues. Symptoms take 2 to 6 weeks to appear in first exposures but hit immediately in reinfected folks. Let's break down the types. Classic scabies has 10 to 15 mites with typical rash and burrows. Nodular scabies features persistent brown red nodules 3 to 15 millimeters on genitals, armpits, or buttocks even after treatment due to hypersensitivity. Crusted Norwegian scabies involves thousands to millions of mites with hyperkeratotic crust on palms and soles, minimal itch but high contagion, common in the immunocompromised. Bullous scabies shows tense or flaccid blisters in the elderly, mimicking pemphigoid. Scalp scabies is scaly and psoriasis-like, mainly in infants or elderly. And infantile scabies brings vesicles or pustules to palms, soles, face, and scalp. Recognizing this helps tailor your approach. Diagnosis start with the clinical assessment. Look for lesions on finger waves, wrist or genitals, plus nocturnal itching in multiple household members. The gold standard is microscopic examination. Scrape a burrow with scalpel, add QH or mineral oil, and check under microscope for mites, eggs, or scabella. Dermoscopy is a non-invasive and quick, revealing the delta wing jet or triangle sign at burrow ends. The burrow ink test including apply ink to a suspected track, wipe it off, and watch it reveal the tunnel. These tools make scabies easier to spot. Scabies is the great imitator, confusing with other itchy conditions. Atopic dermatitis or eczema lacks burrows and has different patterns. Psoriasis can mimic crusted scabies but no intestinitis or mites. Insect bites like papular urticaria has random wheals, not scabies specific spots. Fungal infections like tinea has active scaling borders and positive culture separate them. Always rule this out to avoid misdiagnosis. Successful treatment means killing mites and eggs plus treating all close contacts simultaneously. First line permethrin 5% cream, a topical neurotoxin. Apply from neck down, leave 8 to 12 hours, then repeat in 7 days to catch hatch eggs. Oral Ivermectin 200 micrograms per kilogram interfere with mites nervous system. Repeat after 7 to 14 days. It is best for outbreaks or crusted cases. Alternatives and adjunctive therapies including benzyl benzoate 10 to 25% for when permethrin fails or sulfur ointment 5 to 10% for infants under 2 months and pregnant lactating women though it is smelly and messy. For symptoms, add oral antihistamines and mild topical corticosteroids to manage the allergic itch during and after treatment. Special groups such as pregnant women, permethrin or sulfur is the safe. Avoid ivermectin unless needed. Infants, permethrin from 2 months up, sulfur for younger. Crusted scabies, combine with permethrin with multiple ivermectin doses and keratolytics to peel off crust. Monitor for 4 weeks post treatment. Distinguish treatment failure from post scabitic itch, a lingering allergic reaction to dead mite parts lasting 2 to 4 weeks or more, no active infestation. New burrows appearing after the full treatment cycle indicate failure or reinfestation. Prevention by wash bedding and clothes in hot water over 50 degrees Celsius. Dry high heat. Seal unwashable items in plastic for 7 to 2 hours. Contact tracing. Treat all partners and household members, even if symptom free, to stop the cycle. That wraps up our overview of scabies. From its sneaky transmission to effective management, this knowledge empowers in family medicine. Remember, early diagnosis and contact treatment are key to breaking the itch. For more on medical education topic like this, check out the Docsaab's Diary on YouTube and like, share, and subscribe to the Docsaab's Diary. Thank you for listening and let me know what's your take on managing scabies outbreaks in clinical practice.